So we are pleased to have our last invited speaker of our meeting today, Dr. Emil Schüler, who's an assistant professor at MD Anderson Cancer Center in Houston, and has been active in the area of flash radiotherapy, and will share with us his thoughts on challenges and opportunities in the applications of flash. So Dr. Schüler, all yours.
Thank you so much. Let me try sharing my screen here. Are you able to see my screen?
Yep.
Excellent. Thank you for that introduction, and thank you so much for inviting me here. Very excited. Hopefully next time it will be in person. I think we're all a little bit tired of the Zoom, but it is a good tool in the world we're living in. All right, yeah, so I'm here to talk a little bit about flash radiation therapy. As it's going to be, try to do it in a more holistic way and talk a little bit about everything. Obviously, I'm happy to talk about the specifics, and please ask any questions you might have. Just as a way, I saw this was someone else was doing it on one of the conferences. Nice way to introduce yourself a little bit more, and when you don't have the opportunity to be there in person. But who am I? My name is Emil. I come from Sweden originally. I did my medical physics master at the University of Gothenburg in Sweden, as well as at the University of Hawaii at Manoa on free radical production through nanoparticle composites. I then went back to University of Gothenburg to do my Ph.D. there in nuclear medicine and peptide receptor radionuclide therapy. I was then recruited to Stanford to the lab of Billy Liu and Peter Maxim, where I was then working within flash radiation therapy. And these guys were really the guys who first established a flash program here in the US. I then did a residency followed by joining the faculty at Stanford before being recruited to MD Anderson in the summer of 2020. So right in the middle of it all, still was able to be onboarded here. So there I have right now I'm an assistant professor there on tenure track. So both clinical as well as research based. I am then my clinical component is in the breast service group. Then I have a research group that is within flash radiation therapy. And I'm also co-leader of the Radiation Oncology Strategic Research Initiative within flash radiation therapy from the institutional side of MD Anderson. So the outline of this talk, as I said, is going to be a little bit of everything. I'm going to talk about what flash is and what the flash effect is. Why is flash radiation therapy of interest? The beam parameter or beam requirements for flash radiation therapy is at least is what we know. I'm going to talk a little bit about flash capable systems, but mostly going to talk about the systems that we have here at MD Anderson currently, as well as just a few thoughts about the clinical translation of flash. So just getting started, what is flash? So, before we get into it, I just wanted to talk a little bit about making sure we're all on the same side about the two terms that we use a lot. So the first is flash radiation therapy. This has been defined as the use of ultra-fast delivery of radiation therapy at dose rates generally several thousand times higher than the ones currently used in routine clinical practice. So in the flash setting, the early definition was 40 gray per second and above. That can be compared to the conventional setting, which is along 0.01 to 0.1 gray per second for most treatments. The flash effect is then the phenomenon of the increased therapeutic index of flash compared to conventional dose radiation. That's the biological component of flash when you talk about it that way. So why is flash radiation therapy of interest then? Obviously, I feel like it's a very interesting field to be within, and I hope that I can convince you guys as well that this is the case. So again, why is flash radiation therapy of interest? So flash radiation therapy has been shown to induce a normal tissue sparing effect while an iso-effective tumor effect. So really holy grail, reducing normal tissue, but maintaining or potentially increasing the tumor control. And so really it becomes on the normal tissue side of things. And the normal tissues that have been mostly studied are the brain with preserved cognition, the lungs with reduced fibrosis. GI is something that we have been looking at, specifically we at Stanford have been looking a lot at that, and looking at the GI tract as well as the crypt survival, which is a functional component of GI. And then, of course, skin has also been looked at extensively, both in mice, but also larger mammals. But going through, why it's interesting and why flash radiation therapy, we need to go then back to where it began. And I'm not going to go back to the 60s and 70s, where there's actually a lot of interesting studies were performed with an ultra high dose rate radiation. But I'm going back to 2014, where the field had its renaissance, so to speak. In 2014, this publication from the Favnon group came out from the Curie Institute in France. And it was quite striking, the data that it was showing us, and I know many people were taken by it and skeptical, but also very intrigued. And there was a lot of data in this publication. This was a lot of interesting data. I'm just going to look at or present a little bit of it, and really showing why this was of such interest. This specific figure here is taken from their lung toxicity study that they had. So they were looking at different dose groups as well as different time point post radiation, looking at lung, and this are then histological sections. And they had then the ability to both do conventional dose rate radiation as well as flash dose rate radiation. And when they did a delivery of 17 grade conventional, they see what we always see when we do those kinds of experiments. Early time points is radiation pneumonitis, later time points is fibrosis that are induced. But they had this experimental high dose rate machine that they then took another cohort of mice. They did the same doses and saw no toxicity whatsoever. And they needed to almost double the dose in order to see a similar toxicity profile as it did on the conventional side. Obviously, this is intriguing in itself, but we all come to get used to the fact that if you spare normal tissue, you usually also end up sparing the tumor tissue, and where then the enthusiasm quickly dissipates. But that was another part of that study, is that they also looked at tumor tissue, and specifically at both subcutaneous as well as orthotopic models. And they did show then, as we now come to see, an iso-effective treatment. This is a 2-fraction treatment on a subcutaneous HPC model, 17 grade conventional and flash, really the same response. Again, they did on this HEP model where they did, again, show that after 15 to 20 gray, conventional flash, iso-effective. But here showed that they could dose escalate with flash. Again, it could not do that in the conventional setting because of the toxicity that was introduced. But in the flash setting, they were able then to do a dose escalation and therefore show a better control. This was also shown in an orthotopic lung model that they were using, where lower doses here, 13 to 15 gray in this setting, conventional and flash, showed an iso-effective treatment, but with the added option of dose escalation with flash, which was not possible in the conventional setting. These are data back from 2014, so a lot has happened since then. As I said, Stanford was one of the earlier institutions in the US to get into this field. And we published a lot on the technical component of it, but I'm just showing here some of our biological data. Among other things, we did a brain study where we looked at brain, and in this study we published in 2019, we looked at the effect of 30 gray whole brain irradiation, and then looking at 10 weeks post-radiation. So these mice, they underwent cognitive testing, specifically memory formation and retention tests. And I'm not showing that data here, but we saw an increased performance of these tests in the conventional versus flash radiated mice. When we then looked closer at the hippocampal region, and the reason why we're looking at the hippocampal region, due to its important role in the consolidation of information from the short-term to the long-term memory, as well as in spatial memory. Here we could see a reduced microglial activation, so which is an inflammation marker. And we could see there was a striking difference between conventional and flash. So these are control, always a little bit, a few foci here of CD68 positive cells, which is a microglial activation. Here, this is a conventional where we see a lot of foci, and then here again, a little bit lower on the flash side. This is then the quantification here of the number of CD68 positive cells. This then became a correlation then with the increase in cognitive performance that we also saw here. We also looked at an array of 10 pro-inflammatory cytokines. I'm not going to go through them all, but just wanted to point out that in all cases, flash radiation has either elicited no or a lower increase in these cytokines compared to conventionally irradiated mice. And in many instances, it was at the same level even as the unirradiated control. We are not the only one who's been looking at brain, obviously. There's a lot of studies coming out. I'm having an emphasis here on the first studies that came out on all of this. But the Montefiore Gruel and the group in Lausanne has been very active, and has really been the group that has been producing most of the biological data that's coming out. But what they saw in their studies, again looking at the hippocampal region, and saw preservation of hippocampal neurogenesis. And these are the foci here that you see, and this is in a control setting. This is what we normally see. After whole brain irradiation, that's we stop seeing neurogenesis. And I think that we are all aware of this from the clinical component, and that's why none of us like to do a whole brain irradiation, just because of the large effects that it has on our patients when it comes to memory formation. And this is really clear here. But in the flash setting, they again saw a higher preservation of neurogenesis in the flash radiated group compared to conventional. They also did then a confirmatory study in X-ray flash using synchrotron irradiation. And again, could see a similar similar effect where conventional really you lose neurogenesis, but a slight preservation at least in the flash X-ray setting. Another example again of why flash radiation therapy is interesting is in reduced GI tract toxicity. This is a study that we published last year on GI tract and survival, where we looked at, in the specific one, here is a high dose 16 gray delivery, where we could show that initially this relative body weight versus days after radiation, and we did a total abdominal radiation. We can see initially flash and conventionally irradiated mice both lose weight in similar fashion, but the flash irradiated mice actually regain weight. And if we look at this Kaplan-Meier curve of the percent survival, we see that flash irradiated mice to a dose of 16 gray had almost 100% survival, while the conventionally irradiated mice all died. We correlated this to the number of regenerative crypts. So the crypts are this functional unit of the GI tract, and they are, as a structure, very radiation sensitive. But they have, and the parts of their stem cell compartment is radiation resistant. So even if you do give a dose, the crypts will collapse or die off, but then you will regenerate. So as long as you don't give too high a dose, they will have the ability to regenerate. And this is what we see here. This is a small figure, but with this ultrapigmentation here in the H&E, and it's very easy to count and then quantify. And what we could see here is that the conventionally irradiated mice have a lower number of regenerative crypts per circumference compared to the flash irradiated mice. Then looking at longer time points after radiation, so this is 12 weeks post irradiation for these mice. We didn't, obviously, for the purposes of this, we didn't have any conventional irradiated mice, but histologically we could not see any differences between flash and control mice at this late time point. We also looked in that study at does deceased state alter the effects, and this is here we employed the ID8 ovarian cancer model, which is a very nice model because it resembles the human condition very well, that it metastasizes in the entire abdominal cavity. And we looked at both the tumor response as well as the normal tissue response. And the normal tissue response, again, I'm not showing them here for purpose of time, but there was the normal tissue response was the same as we saw in healthy mice. But these mice then, from a disease perspective, from the tumor perspective, showed the same percent survival. So we'll, of note here, we lowered the dose to 14 gray so that both groups had the possibility of surviving the treatment. But they both die from their tumor burden in a similar fashion. This is also shown here in these figures. This is a number of solid tumors, as well as this is then the tumor weight, because it's a metastasizing model. We're looking at both the number as well as the total weight, and showing while both groups have a reduction compared to control, there is no differential effect between flash and conventional, again showing that this is mostly a normal tissue effect, and at least less to an extent a tumor effect that we're talking about. Just to bring this to of these examples, to bring that to a conclusion, flash effects are also being confirmed in higher mammals. This is a study again coming out from the Lausanne group, both of these. This was published back in 2019, where mini pigs were irradiated. Mini pigs is a very good model for skin and skin toxicity. Mice are good for many things. Skin is not one of them. But they looked at a dose escalation from 28 to 34 gray, single fraction, delivery either conventionally or flash, and conventional show large necrotic lesions at all dose groups, but in flash setting, they only see epilation. And the Lausanne group also did the first phase 1 cats trial, where they did a dose escalation from 25 to 41 gray, single fraction, to nasal squamous cell carcinoma, and really showed excellent results here. In 5 out of the 6 tumor were controlled, minimal toxicity. Again, hair loss is what the effect that they do see. So you can actually see the field that they're using here. Otherwise, no limitation in tumor intake or smelling capability. And based on this data, they are now recruiting for a phase 3 trial, on a clinical trial with cats with squamous cell carcinoma, and where they're also then including fractionation as well as single fraction treatments, and comparing that to the standard of care right now. Obviously, I can't do an overview presentation without mentioning the first ever patient ever irradiated with flash dose, or at least a planned delivery. This case study was published also in 2019. It was on a 75-year-old gentleman with disseminated cutaneous T-cell lymphoma. This specific patient had progressed through multiple systemic regimens over the last 10 years, had been treated with 110 courses of radiation therapy, localized radiation therapy, but still 110 courses. Had usually done a fractionation pattern of 20 to 21 gray in 6 to 10 fractions, good local tumor control, but had always experienced severe toxicity due to the treatment. So this patient was treated on a trial with 6 MeV flash beam, 15 gray delivery, single fraction, 167 gray per second. And really the maximum toxicity occurred 15 days post-irradiation with a maximum erythema grade 1, which is basically a little bit reddening of the skin, and a 5-month complete response, and really saw no long-term toxicity. They performed optical coherence tomography on this patient, and the only differential effect I could see was a limited increase in the vascularization. So I know that this specific patient has been treated more, and also been comparing again flash versus conventional on this patient. If nothing has happened during the last few weeks, that has not yet been published, but I know that that is on their way out as well. So while in this specific setting doesn't say anything about a flash component or flash effect, it was indicative just because of the prior response that this patient had that there was some kind of flash effect occurring with this lower than normal toxicity that he saw. So that is just a quick overview, a little bit what has been seen. Obviously, there's a lot more that has come out since then, but that is some of the interesting data that we do see. However, flash has been shown to not always be the easiest to induce. The early definition of 40 gray per second and above, or at least a 40 gray mark, seems to be a little bit low compared to what the data we're seeing, as well as there are other beam parameters that is of importance when it comes to the flash effect. So while FLASH represents a promising new approach to increasing therapeutic index, there's a lot of challenges to FLASH. It comes both from the dosimetry perspective, where our normal go-to with ion chambers is not the go-to when it comes to FLASH. And we've had to use a lot of detectors and dosimeters that are passive in nature and requires a long readout, and also requires a different kind of expertise compared to the normal detectors we're using. So definitely a challenge. Another challenge has been in accessibility as well as reproducibility of the machines that can do this. And that's why it took a longer while before this was a broader field. And I think it's still being held back by the fact that you don't necessarily have a FLASH capable machine just standing around waiting to be used. It requires either a conversion of clinical linear accelerators, or you need to buy the equipment, which is obviously both expensive as well as shielding requirements. But currently, most of the research within FLASH is within electron beams, and specifically pulsed electron beams, because that's the normal way that we are generating radiation. And there are evidence that it's not only the average dose rate that is important, that there are other effects from the beam parameters that are of importance for the magnitude of the FLASH effect that we're inducing. Some of these are the pulse width, which is the time it takes to deliver one pulse, as well as the mean dose rate, obviously, that we have talked a little bit about. The intra-pulse dose rate, or the instantaneous dose rate. So that's the dose rate within the pulse. The dose per pulse and pulse repetition frequency, and related, the overall radiation time. And the dependence on the FLASH effect from these parameters have yet to be determined. But there are indications that there are importance here as well. Obviously, this is now more related to the electron FLASH, not the proton FLASH, because that has a different pulse structure. But as a recommendation, or at least the mantra that I'm trying to go by in my own research, is that if there are already indication that has to do with more than just the overall delivery time when it comes to the FLASH effect. So any system that is brought in to investigate the FLASH effect then shouldn't then reasonably have a capability of varying most or all of these parameters in order to find an optimal set to maximize the FLASH effect. So what do we know about it? So there are indications, people are talking about it, but what's actually been published on it? Burriz et al., also back in 2019, tried to look at the data that has been published so far. And there's an updated now, this figure here has been updated, basically shows the same thing. So I've kept this one for clarity. But he tried to look at what parameters are there, and just very quickly looking at the positive studies that so far had been published on the FLASH effect, and what the radiation time, the overall radiation time versus the instantaneous dose rates. What can we elicit from this information? So if we exclude this point here, which is probably should not have been here anyway, because it's an X-ray beam with it's a sliding window. So so it's not really you don't deliver the entire dose in entire field in one go. You're scanning across it. So you can argue that this needs to be calculated in a different way. But otherwise, looking at the other data that we have, it seems like there are indications that you have to be in the close to 10 to the power of 6 gray per second in your instantaneous dose rate, as well as an overall delivery time of 100 to 200 milliseconds. That is the what could come out of this this analysis. But looking at trying to, again, what kind of studies are there to look specifically at the different parameters? And again, there's not a lot out there. There are 2 studies looking at more the dose rate dependence. There are some other interesting studies that come out recently, but these 2 studies here, this study here on your left will be the Monterey-Gould study from 2017, where they did a dose rate response study, whole brain irradiation, 10 gray, looking at a recognition ratio, so a functional endpoint in memory formation versus dose rate. So it went from 0.1 gray per second, 1, 3, 10, all the way up to 500 gray per second, and then everything delivered in 1 pulse. And these are then unirradiated controls. What could be seen here was that in order to start seeing an effect, 30 gray per second was needed. But you needed to go up to about 100 gray per second in order to stabilize the sparing that you saw. And after that was more of a plateau. We also looked at that at Stanford and are currently working on improving the details of this. But this was a whole GI tract irradiation looking at survival specifically. So probability of death versus dose down here. And what we could see if we irradiate our mice conventionally, the LD50 is about 14.7 gray. Doing a 70 gray per second delivery increases the LD50, which is then the lethal dose for 50% of the population, to 16.6 gray, and we further increase the LD50 to 18.3 if we deliver the doses with 220 gray per second. So at least in these 2 models, there is a mean dose rate effect that is occurring. And really that is the most detailed data that we have when it comes to these parameters that I was talking about that are more than just suggestive of the nature. So I usually go by the fact that the only proven effect is the mean dose rate, and that is the other are yet to be determined. But I think we're going to be seeing much more of that going forward when we're trying not only to introduce a flash effect, which many of the studies are doing, just trying to introduce it. But now when we come into the next phase of the research, where we're trying to maximize it and understand it, that is when the parameter-based approach is going to be more important. But obviously, in order to study this, you need to be able to deliver it. So some flash-capable systems, and I'm just going to be selfish, and I'm going to talk about the systems that we have at MD Anderson. For the sake of time, there is many systems out there, many very interesting systems, and would love to dedicate a future talk just to that topic. But some of the systems that we have at MD Anderson currently are in the process of installing is the Radiotron. This is one. The Radiotron, that's a system that was used in and still is used in Lausanne, and they have published the most extensively in the published literature based on this system. And it's a prototype linear accelerator that was originally designed for radiobiological effects of high dose rate electron beams. This system, this system that we're installing is a little bit updated compared to what has been published in this one. But it has a nominal beam energy of between 5 and 7 MeV, capable of dose rates from a few gray per minute to more than 1,000 gray per second. The pulse width can be varied between 0.5 and 4 microseconds, and the pulse frequency can be varied from 5 to 250 hertz. Also different field sizes depending on your SSD, obviously, and an SSD can be a variable parameter. This is how in the program that we are building up here at MD Anderson are thinking of as our dedicated preclinical system used for cells, smaller animals, as well as equipment development. Just in order to elicit a little bit more usability out of this system, we're actually putting it on a gantry capable then of rotating it, as well as introducing a wheel where we can have our standard collimators on there, as well as more variability and easier manipulation for any end user to use this. Our other system that we're currently working with that we have on site is the Mobitron. The Mobitron itself has been on the market for quite some time, but it recently got an update and is now capable of producing flash dose rates. The energy is either 6 or 9 MeV with dose rates up to 1,000 gray per second. Again, the pulse width can be varied between 0.5 and 4 microseconds, and the dose per pulse can be up to 11 gray. The pulse frequency can vary between 5 and 250 hertz, at least the system that we have. And the field size is 5 centimeter and above. So the features of using the original Mobitron using conventional dose rates are still there. And it is for the user to simply switch between what they call then the standard mode and the high dose rate mode. We say, unfortunately, named the HDR mode, which can be a little bit annoying when depending on who you talk with. There is also a separate controller for setting the pulse width and pulse repetition frequency, and the system uses a number of delivered pulses at their beam control parameters. But that's also a feature that is currently being upgraded. Currently, our last system that we are working with on the electron side here at MD Anderson currently that we have up and running is the Elekta Versa, a converted Elekta Versa. So Lampard et al. Had a very nice publication about how to convert a Elekta unit, much like the one we published earlier on the conversion of variant Clinax. And while an Elekta Versa and the Elekta units are capable of delivering between 6 and 22 MeV electrons, the conversions are made for a 10 MeV electron beamline. Dose rates that you can get is 1,000 gray per second and above, depending on your SSD, with a maximum dose per pulse of 5.1 gray that was presented in this publication. The pulse frequency can be set up to 200 hertz, and depending on SSD, a field size of 7 centimeter and higher. The control of the beam, then an external diode was used in this original. As long as you have a signal to be able to measure the number of pulses, then you can use any type of external device and bring that into your own microcontroller. And you can connect that directly to the Diatron for direct pulse control. Pulses are counted through signal processing of a diode signal in a specific case, and the measurements are performed on a rising edge. The updated performance of this system is that it can deliver 200 gray per second with 1 gray per pulse at 100 centimeter SSD with a field size of 12 by 12. So it becomes a very interesting system for a clinical translation project, if that is what is desired. At MD Anderson, we're always, so obviously from the electron point of view as well as from photon point of view, we're always looking for new systems, especially looking to have systems that can penetrate further in tissues. For now though, we do not have a system on the electron side, and we do not have a photon system yet. We're working on that currently. But we don't have a good system for deep-seated tumor, to get into deep-seated tumors. However, we do have a proton flash system also, and this system here is something that we are looking into to see, can we also then use them in the patient setting. Currently, it's been optimized for preclinical radiation. So at our proton therapy center, we had this ocular beamline attached, which was built original with our facility, which is a synchrotron-based facility, it had never been used. So when all of this came to be, we started to look into how can this be modified to do flash radiation. So originally, this is a fixed double scattering beamline designed to treat ocular disease. And it's a single proton energy of 87 MeV, equipped with your normal components that you have on these double scattered beamlines. So in order to provide flash beam conditions, the first scatterer, the modulator wheel was removed, and a custom design beam modification device were introduced. The range shifter could not be removed, so we simply just moved the entire platform earlier on. So we basically in this position here, you can see in this illustration. Of course also other beamline components which were not removed were like the reference chamber monitors that we can still then use to calibrate this beam. This is just a general design as well, just zooming in a little bit. We put our mouse here, we just build it up with plastic and having very clear spots where we always place it for indexing purposes. Of course, before it even comes into this level, to get a useful beam with scattering foil, flattering filters, energy filters in terms of a ridge filter, as well as range compensators to have a very highly controlled field that we're working with. And these are some of the examples. This is actually, it was just accepted now in medical physics, so it will soon be out for everyone to view. This is our beam when we spread it out, but still it maintains its pristine Bragg peak. And this is when we are introducing then a spread out Bragg peak through our ridge filters. This is just a depth dose, depending on how then if we do not trying to do any type of spread out Bragg peak, and then if we want to do a 1, 1.5, or 2 centimeter spread out Bragg peak. And this is just showing our profiles, which are very nice, flat. Of course, any type of filtering, so going from just a pristine Bragg peak down to first of all scatter field as well as a spread out Bragg peak. While we can get very nice field sizes, we do lose we go down to about 7.6% of the output. Still more than enough for what we need. We can get field sizes on this specific one up to 20 by 20 by 20 millimeter cube. But obviously we can modify that accordingly. So that's why I'm saying it's right now modified and optimized for preclinical radiation. The doses that we can deliver, everything has to be within 1 spill, so to speak. If you talk about synchrotron-based systems, talk about the spills. So everything has to be delivered within 1 spill in order to achieve the flash dose rate that are needed. But the doses we can deliver are 10 to 140 gray within that spill, and the dose rates can then be modified between 0.5 and 5,400 gray per second. I just wanted to take some photos as well, just how it looks. This is obviously a modification of an existing beamline, so you have to work with what you have. And this is the platform that we then put our mouse on. This is then our mouse setup, which has then been indexed onto here. And this is just our 3D printed jigs that we're using for these animals as well. Unfortunately, I couldn't get the data ready in time, so I can't actually show you any data from this specific trial, but just showing that we are definitely a team behind all of this. I just have, based on my clock here, just another minute for this presentation. So just some quick words about the clinical translation of FLASH. We published a review just a few months ago looking at clinical translation specifically. And this is just at the time when we prepared this, what kind of systems are there for clinical translation right there and then that had published parameters associated to them. So we have the like the Elekta Precise conversion, similar to the Elekta Versa that we did from Lund University, the Varian Clinac conversions that Stanford and Dartmouth have performed are definitely systems that also can be used for clinical translation. And then CHUV has published on the Oriatron as well as the PMB Flash Knife, which are also very interesting systems when it comes to the clinical translation. And in this list is not the Mobitron has not been introduced just because there was no publication out then on the Flash Mobitron. University of Pennsylvania has published a lot on their IBA Proteus Plus system. But there are also other proton systems, for example, the Mevion system, and as well as the Varian Probeam system. But current active trials, as far as I know, these are the two. There are many in preparation, but these are the two. There's one in CHUV in Switzerland, and another one on protons in the Cincinnati Children's Hospital. The one in CHUV is going to look at tumor control on melanoma skin cancer, and really looking to establish doses for future phase 2 trials, as well as feasibility. The Cincinnati, which is called the FAST-01 trial, while it is at the Children's Hospital, is not is adults being enrolled in it. It's a single-arm prospective feasibility trial sponsored by Varian Medical Systems to treat painful extremity bone mets. And really looking to deliver 8th grade ×1, and just looking at the feasibility of it and making sure that they're not doing more harm than what they usually see. So first step, necessary first step that needs to be taken in order to get to the next round of more informative clinical trials. I'm going to go directly to this one due to time constraints, but Flash RT, is it really the new paradigm? There are a lot of questions still that needs to be answered. For example, what are the biological mechanisms of Flash? As you noticed, I did not even touch upon that subject here. That was in purpose, because I believe that you need to have the time to really go through it in order to get a good understanding of it. But there are many hypotheses out there and many versions of the same hypothesis. So definitely take some time to go through it. But it is interesting, very interesting, research in itself, just to understand the mechanism behind the Flash effect. But we are so new into this field, so we haven't even answered what is the minimum dose that can be delivered and still introduce a Flash effect. What is the space for fractionation or even multiple beams in this realm? And what are the differential effects of Flash on different normal tissues? And again, a question that has not been answered. What we do know, though, is that the Flash effect is real and has been demonstrated with electrons, photons, protons, even heavy ions. The Flash shows normal tissue protection with at least isoaffected tumor control. And dosimetry and beam control are critical parameters for reproducible and robust effect. With that, I just want to say thank you to all my teams, all my collaborators. Obviously, anything that within this realm is a great team effort, but I'm always afraid to put on names here, but these are some of the few people that are involved in all of this research. And I want to thank you guys for sticking with me and listening to this, and any questions, please. I'm ready to answer. Thank you.
Well, thank you very much, Emil. That was really interesting. I don't see questions in the chat. Does anyone have questions for Dr. Schüler?
I have a question about, do you know about this topic? Do you know if it's any difference between the PDDs and profiles for a flash versus a conventional beam, say with the same energy and same field size?
No, in that case, obviously it will depend on which
System you're using.
which system you're using, absolutely. But
assuming
no, we have tuned our own beams to be matched when it comes to PDD as well as profiles. So it can be done at least. The problem that is usually seen is that when you try to do flash, you might reduce the materials you use to scatter the beam, and therefore you will elicit a different scatter component and a different energy profile throughout the beam. And that will cause, even if you can say, oh, it's still a 9 MeV or a 16 MeV electron beam, it can look very different because your spectrum is different. But that's not the approach that we have had. We have tried to keep our beams as close, as similar as possible, and just trying to really pump more out of the system. And we've been quite successful with that approach.
And I have another, not really a question, almost like a comment. I was just thinking about the future challenges for clinical cases to do a composite dose between prior treatment with standard dose rate and flash therapy. I am assuming none of the biological models that we have will be applicable.
No, there is, I want to just mention that we don't even know what the flash effect and what the parameters needed for that is. So composite that into anything else, there will be way too many question marks that I don't even want to approach and commenting on that more than this.
Yeah, just came to my mind that is like a challenge for the future.
Can you comment also on the dose rate, instantaneous dose rate versus kind of average dose rate over many pulses, and also on timing? So the one dose rate is one thing, but then the duration of a pulse, especially the nanopulses of an accelerator, might be important.
Absolutely, and I touched briefly upon that when I was talking about the beam parameters. The only robust data we have is that the overall delivery time is important. So, and that of course translates into a mean dose rate across all pulses delivered. But when it comes to the dose per pulse, as well as the instantaneous dose rates, which will then obviously be related to the pulse width as well, there are indications that the dose per pulse and instantaneous dose rate are important as well. To what degree they are important is still a very much an open-ended question, and one that we are currently looking into ourselves in trying to do a more mechanistic approach to elucidate that, because it can be also minor effects in a in vivo system might be lost due to the inherent uncertainty when it comes to a biological endpoint.
Well, thank you again, Dr. Schüler. I think that takes us to the end of our invited talks, and I want to thank all the speakers again. And